Chadi Nabhan here with the Hem-Onc Pulse and Blood Cancers today at ASCO, the American Society of Clinical Oncology in Chicago. And I'm here with the one and only, the legend, the myth, Dr. Alex Herrera. I gotta shake your hands because you were up there on the podium on the plenary session. So congratulations, this is really wonderful.
Thank you.
Before I start asking you the tough questions,
okay.
Tell us a little bit just about what you presented in general and what the results were.
Absolutely. So, we designed this randomized phase 3 trial in patients with advanced stage Hodgkin lymphoma. And, we wanted to test a novel therapy, nivolumab, which is a very targeted therapy for Hodgkin lymphoma. It kind of takes advantage of these genetic changes that are present in the Hodgkin lymphoma tumor cells that result in overexpression of the PD-1 ligands. And so we know that it's an effective therapy for patients with more resistant disease. And this trial was testing it in the front line, combined with chemotherapy. So nivolumab combined with AVD chemotherapy, compared to a current standard, brentuximab vedotin, combined with AVD. Now, there's a long history of how we've treated this disease, how we've escalated therapy over time for decades with radiation and chemotherapy, and ultimately, started to see some of the late effects because this disease affects the youngest patients in their teens, 20s, and 30s. And so, ultimately, we've treated this disease really differently around the world. In Europe, they use a regimen, many places use BIACOP. In the US, we used ABVD. Pediatric docs in the US use a different regimen, ABV-EPC. And then when brentuximab came along, we saw that it improved outcomes when we combined it with AVD in adults or AV-EPC in pediatric patients, but it's not a perfect combination. There are patients who still relapse. It adds toxicity in adults to do that. We still use all these different regimens. So this trial, this randomized phase 3 trial, sought to harmonize the treatment of pediatric patients and adult patients. The goal was to improve the progression-free survival in these patients using nivolumab compared to brentuximab vedotin AVD.
Was there an upper age limit for this trial?
No, it was not, and that's a big difference from prior trials in the North American cooperative groups. This trial was led by SWOG and was done in collaboration with the other adult pediatric cooperative groups in the United States. Our prior trials in the adult cooperative groups incorporated BIACOP, and so there was always an upper age limit. But with this trial, there was no upper age limit, and we enrolled patients as young as 12.
And this is for our viewers and listeners really is great because, elderly Hodgkin is a known phenomena. Maybe you can explain a little bit why the importance of no upper age limit. I find this really important.
Right, so there's this bimodal distribution of when Hodgkin lymphoma can present in humans. And so, we see it affects young people for sure, in their teens, 20s, 30s. There's also a late peak in incidence. Patients, can be in their 70s, 80s. And so we actually have quite a number of older patients with Hodgkin lymphoma, and we know that their outcomes aren't as good with our standard therapies, and that's probably for two reasons. One is the biology of older patients with Hodgkin lymphoma seems to perhaps lend itself to not being so sensitive to therapy, but also it's harder for them to tolerate the therapies that we give. In fact, for years we've been using bleomycin as part of these regimens, and they're at much increased risk for lung toxicity. And now that we've incorporated brentuximab vedotin, again, in the trials that showed that brentuximab vedotin improved outcomes in adults compared to ABVD, that difference wasn't really there, and that the benefit wasn't seen really in these older patients. So this trial, not having that upper age limit, really allowed us to ask this question: can we use what we at the time thought would be a better tolerated therapy with nivolumab AVD, but also improve outcomes in this patient with high risk disease?
I love that about the trial. So, what did you show?
Yeah, so in this randomized trial, we enrolled nearly 1,000 patients. It was a representative trial. A quarter of the patients were under the age of 18. 10% of patients were older patients above the age of 60. A quarter of patients were Black or Hispanic. We had good representation of high clinical risk patients with a high IPS, intermediate or high IPS score. And in this really representative trial, we saw actually that nivolumab AVD improved the progression-free survival compared to brentuximab vedotin AVD. The hazard ratio was 0.48, so it was a 52% reduction in the risk of disease progression or death. The 1-year progression-free survival was 94% with nivolumab AVD and 86% with brentuximab vedotin AVD. So really, and I should say, the reason I'm talking about 1-year progression-free survival is because this study actually met its study endpoint early. So this was just a second interim analysis at 50% of the anticipated events for the final analysis. And the difference was already so dramatic that the PFS primary endpoint crossed the statistical boundary, and it was recommended that we report the results. The study question was answered.
And overall survival is obviously the same yet, and I'm sure you're going to follow this, and so we don't know the results. So in the absence of overall survival benefit, you're leaving ASCO, going back to California, are ready to switch your practice tomorrow.
So I guess I'll say one thing about the overall survival. There were 11 death events in the brentuximab vedotin arm and 4 in the nivolumab arm. So numerically, there's already starting to be a bit of an imbalance. It's still early, right? These data aren't mature. So what I'll say is I am not comfortable yet saying that the survival is the same yet. There's already, so maybe it will end up that way, but we just have to follow the patients more and see. Now, when it comes to practice change, there's a regulatory submission plan with these data. Obviously there are guidelines panels, and to be considering these, the incorporation of this regimen, especially once we have the full data set out and published. In my view, the older patients that we were talking about are especially the patients that could benefit from this regimen sooner. Whether it takes time to get all these things in order from a logistical perspective, but I view this study as likely practice changing. If we can improve outcomes, disease outcomes, if we can reduce acute toxicities. And in this trial, something I haven't mentioned yet is that most of the time pediatric patients received radiation with the old approach. With advanced stage disease, 55 to 60% of the youngest patients were receiving radiation. And so in this study, less than 1% of patients received radiation. So if we can improve outcomes, improve acute toxicities, remove radiation, which presumably will improve late effects, I don't, this study is, I would assume it's practice changing as long as all of this holds up.
I mean, it looks like it, and really congratulations. This is wonderful. I guess my last question is, what's next for this patient population? I mean, 94%. I mean, Alex, I'm not sure you're gonna, I'm not gonna speak for you. So you tell me, what's the next study?
Right.
Whatever you can share with us.
So I think there are two obvious questions, and I think as we sit and think about this more, there will be more. I think there are two possible next steps. Brentuximab vedotin is actually a very potent drug for Hodgkin lymphoma. I don't think we should be abandoning it, of course. So the question is, do we reintroduce it, right, as a better microtubule inhibitor than vinblastine? Now it's
with NAVD.
Right. So there was a phase 2 study presented by Hunley last year from MD Anderson at ASH that looked at brentuximab vedotin, nivolumab, and doxorubicin and dacarbazine. The outcomes looked good. So I think that's one question, right? Do you do BV-Nivo AD versus Nivo AVD? That's simple, 1-to-1. That's part of the beauty of this trial was its simplicity. AVD backbone with one or the other drug. I think the pediatricians would be excited about that because they showed in their trial that BV improved outcomes compared to their old standard. So I think that's one route. What is the role of BV, and do we reintroduce it into frontline therapy? Or alternatively, like you said, we've achieved really good outcomes. Do we think about biomarkers, whether it be quantitative PET measures, circulating tumor DNA, to kind of de-escalate or escalate therapy, adapt the therapy to make sure some patients need BV to be de-escalated. Yeah. Maybe some patients can have fewer cycles of therapy. So there's kind of two different approaches, right? Kind of maximize cure or start to tailor therapy. And as a field, that's something that we need to think about now, but it's an exciting place to be.
Alex Herrera, Dr. Alex Herrera, the myth and the legend, right here with me. Thank you so much.
Thank you so much.
Congratulations.
Really appreciate the time.
Congratulations.
Thank you.